Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from F. Hoffman LaRoche Limited.
This program is presented by Medscape Education Global.
Hello everyone, welcome to this program entitled Patient-Centered Paroxysmal Nocturnal Hemoglobinuria Treatment and the Role of Terminal Complement Inhibitors. I'm Régis Peffaud-Latour. I'm at the French Reference Center for Aplastic Anemia and PNH in Saint-Louis Hospital in Paris, France. And in this activity, Tala Munir, Rachel Payne, Richard Kelly, and Austin Kilakis-Araraj and myself will discuss how to implement evidence-based holistic management approaches for PNH, ensuring they are tailored to patient preferences. In this first chapter, I'm going to discuss PNH. How does it impact patients? What is PNH, first of all? PNH is due to a somatic mutations that is arising in the PGA gene, which is located to the X chromosome, and is responsible for the synthesis of an encore, a GPI encore. And basically, if the enzyme that is supposed to build this encore is misleading, then you have several molecules that are not attached at the cell surface. And among those molecules, we have two ones very important inhibiting the complement, the CD55 and the CD59. Basically, what we do know from years is that the complement is constantly activated on our cells to protect ourselves from infections, for autoimmune disorders, or even cancers. And if you don't have those complement inhibitors, then your cells are destroyed. Let's come back to this picture. On the left, you can see a normal red blood cells wearing those complement inhibitors. And as you can see, there are intact red blood cells while complement is activated. On the right side, you have a mixed chimerism with a mixed hematopoiesis of normal cells, but also some cells who are missing complement inhibitors. Those cells are the PNH cells. And because the complement is constantly activated, they are destroyed because they cannot inhibit the complement activation. And this is responsible for most of the signs of this disease, which impact drastically patient lives. As you can see here, because of the destructions of the red blood cells, there will be what we call hemolysis and then anemia, and obviously a low level of hemoglobin and then fatigue. There will also be some consequences because of this hemoglobinuria and hemoglobinemia and hemoglobinuria with dysphagia, with erectile dysfunction in male. And one of the most important complications that might arise is thrombosis. Those thromboses are located in specific location, mesenteric veins, Budd-Chiari syndromes, or even brain. We don't really know why they are occurring and when they are occurring and why so specifically in some locations, but they are extremely devastating because before complement inhibitors were available, there was a median overall survival of 22 years in this disease because of thrombosis occurrence. So you see here a global vision of the treatment burden in those patients. Basically, those patients are experiencing fatigue, hemoglobinuria because of anemia, renal dysfunction, and as I was telling to you, possibly thrombosis associated with the prognosis. So there was a revolution in PNH 20 years ago when C5 inhibition was available. Basically, when we were able to block the C5 at the terminal level, we were able to protect patients from thrombosis occurrence, improving drastically survival and bringing them to a almost normal quality of life. However, there is still some treatment burden Of course, the patient needs to be close to the hospital or at least coming to the hospital, even if home care has developed. He has to be followed in the hospital. At the moment, C5 are injected, IV or sub-Q, and then obviously you can have some pain or discomfort at the site injections. There are an impact on your life, especially for adults regarding work or even kids regarding school. And last but not least, those drugs are quite expensive and you can have a financial concern because of those treatments. So at the moment, we do understand that it's very important to have some tools to appreciate the consequences on patient lives. And it has been developed some patients reported outcomes tools. From the beginning, we tried to adapt some existing tools to PNH with a limited number of items. There was the case for the ORTC QLQC30 and the fatigue score that were used in the previous and preliminary clinical trials. But the problem is that those tools are not fully adapted to PNH. In the more recent years, we try to adapt some of those tools or to develop new ones to have more items and to be able to specifically address the symptoms of the patients. First of all, the ORTC IL-4T has already been used through the Komodo studies, and we have some data published and very interesting because it's more specific to PNH with more items dedicated to this disease. On the other way around, we have two new tools dedicated to PNH, the QLQ-AA PNH 54 and the PNH SQ. Those tools must be, hopefully will be validated through the IPIC registry, and we will have finally a tool completely dedicated to PNH. So why is it so important to develop those tools? But just because we want to understand the consequences of this disease on the patient's lives. And we want to understand precisely through a daily care and routine, but also through clinical trials. We want to see if the patients need more treatment, psychological supports, or anything might help. And this is really something that we help to address those issues. So thank you very much for your attention for this first chapter. And please continue on to listen the next one titled My Life with PNH.
Hello, welcome everyone. My name is Talha Munir. I'm a consultant hematologist working in PNH service at Leeds Teaching Hospital NHS Trust in Leeds, UK. Joining me today is Rachel Payne. She's a patient with PNH. This chapter is very much focused about Rachel's experience of living with PNH, and then I will give the hematologist point of view on the impact of treatments on PNH patients. And together we'll discuss why there may be differences between the approaches that clinician takes and the PNH patient's views on that. So I'll hand over to Rachel to share her story with us. Over to you, Rachel.
Thank you, Tella. 10 years ago, I was diagnosed with PNH. I had about 6 months of feeling lightheaded and dizzy. And I was in and out getting blood tests and they couldn't really work out what was going on. I did end up in ED where I had some extreme stomach pain. And they didn't diagnose me at that appointment, but 2 weeks later at my follow-up, I came out with a diagnosis of PNH. At the time, the only treatment that was available was eculizumab. Now, obviously, eculizumab didn't work well for some people, didn't really work well for me. What I know now was I suffer from extravascular hemolysis. So during my time on eculizumab, I actually never had a hemoglobin higher than about 70, maybe 80 with a blood transfusion. So of course I was left with all those typical symptoms of the fatigue, the brain fog. So I've been on a couple of drug trials. The first was for a injection every day, which didn't work for me. And then the second was actually a phase 3 trial for pegcetacoplan, which was a game changer for me. The only downside was that the minute there was a whiff of some sort of illness or something going on around me, and my immune system ramped up, I would crash, and I would crash hard. I would go from 115 to 73 the next day, which was very challenging and very scary the first time it happened, because I actually was, it was the worst I've ever felt with PNH. And there was probably also a greater mental impact on me than I was expecting. The fact that I was taking medication home with me and it was being done at my house instead of being done at the hospital, where I could leave and put some separation between me being sick, it just really reminded me that I was a sick person, and I guess I couldn't sort of turn away from that. A couple of years ago now, me and my partner made the decision that we wanted to try and have some kids. So my specialist recommended that we change to ravulizumab, which again had similar experience, or have similar experience to what I had with eculizumab, in that I don't have a normal hemoglobin, and there are things that are not as good as they could be. But it has actually been a much more positive experience for me mentally, because I go every 2 months, and then I go in, I get my treatment, and I walk out the door, and then for the 2 months I can be kind of free and think I'm not quite a sick person. I, of course, have the fatigue, and the brain fog is still a problem, and these sorts of things. But there is something to be said about mental health being a huge part of this journey as well, and how much it actually impacts on me and then my health outcomes as well. But I'm really excited about what's coming, because sort of every time I'm in and I'm chatting with my doctor, it's, oh, there's this happening, or we could try this. And they're pretty keen just to get me sort of involved, and they understand how important it is to me to have that balance and to be treated not just as a patient and not just what the labs are telling, but also what is the best overall outcome for me to actually have a life, have a quality life, and try to balance all that sort of thing. So yeah, I'm really excited for the future of PNH and how it's treated, and how doctors deal with their patients.
That was fantastic, Rachel. And I'm just going to give a hematologist point of view. I think the focus for clinicians right at the start of the treatment for PNH is very much focused on how to prevent complications of PNH, and our focus is to prevent any thrombosis or any end organ damage that can happen from PNH. And that does require looking at lab values and making sure that we have controlled the hemolysis pretty well. And in the midst of that, once somebody is on chronic therapy like complement inhibitors, one of the focus that we always have is that we're not causing any harm to our patients, and reducing the risk of meningococcal infection is a very important aspect of what we are looking at in terms of hematologist. But in the midst of that, you're absolutely right that all of this treatment needs to be given to prevent complications, but also to improve the quality of life. And I think the clinicians are becoming more and more aware of that. The improvement in lab values may not always translate to quality of life improvement for our patients. And I think that is something that comes with experience with treating PNH, where there is a lot of PNH expertise. These kind of questions are asked in clinics, and clinicians are aware of that. Whereas if you have got very limited experience, then that may not always be the case. So I think one of the questions that I've got for you, Rachel, is that why do you think that the patients and physicians have these different focuses on the impact of treatment of PNH, and how can we explain that?
I think it comes back to what the, I guess, fundamental value is of medicine, and why people become doctors is they want to fix people. They want to, make people better. They want to see people they want to save lives. Sort of, they're wanting to make an impact, and one of the, I guess, key focuses, and it's not just in medicine, it's everywhere, is that we've got an easy way of measuring that by looking at lab values and going, we know this is what a normal person should be, so our goal is to get those values to there. And that doesn't always correlate, as you just said, with actually giving a patient quality of life. And I am really positive about the changes that are happening in the 10 years I've been diagnosed compared to where I was at the start, where it was, you've got to get treatment. This is the only option. This is all you can do. Who cares if you're not well? Like if you're not doing well mentally. Whereas now there's a lot of this sort of stuff happening that, I'm really sort of positive for what the future holds for the treatment of PNH and other chronic illnesses. And I have a question for you, because we have made some improvements. We can see over the last few years there's been a lot of drugs that have coming out, but we're still maybe not got the perfect one. So how do you think we can address the fact that some of these drugs, or the drugs that are coming out, are better but maybe aren't addressing all of the symptoms and potentially bringing their own symptoms with them?
That's a fantastic question, Rachel. And I think with any chronic disease, we are going to be seeing different patterns of disease patterns in different patients, and we need to think about individualizing therapy for individual patient depending on their needs. So we are in a good space with PNH now, where we only had one or two drugs, but in the last decade or so, we've got a number of molecules which have actually now got the license, and we are able to use those molecules for patients depending on their needs. So you clearly highlighted your journey, and you've been on 3 different drugs, and essentially that's the journey that a large number of PNH patients now are getting at this moment in time. But what I'd say to the patients is that we now have options, and we need to tailor those options depending on your needs. And for some patients, having an infusion every 2 months is important. For some patients, they do want to keep control of their PNH and they want to inject themselves once a month, that kind of thing. We do all have those options. When it comes to extravascular hemolysis, we're talking about tablets, we've got subcutaneous treatments options. So there are lots of things that you need to consider when we are treating our PNH patients. And I think the clinical outcomes as well as the quality of life outcomes are becoming a very important question in all of that debate. And I do feel that these quality of life questions and the engagement of the patients in the clinical trials have become so important that they are becoming an exploratory endpoints for a number of clinical trials. And I think this is hopefully going to help us to individualize therapy for individual PNH patient, and that's my hope for future. So I would like to thank you, Rachel, for sharing your fantastic experience, and I would like to thank the audience for your attention. Please continue on to listen to the next chapter. Thank you.
My name is Richard Kelly. I'm a consultant haematologist at Leeds Teaching Hospitals in the United Kingdom. In this chapter, I'm going to present the available patient-reported outcome data from the clinical trials on terminal complement inhibitors in PNH. The 3 terminal complement inhibitors that I'm going to discuss are the ones who've gone through phase 3 clinical trials. So that's eculizumab, ravulizumab, and crovalimab. All of these terminal complement inhibitors block C5 from forming C5a and C5b. When complement is activated in patients with PNH, uncontrolled complement activation leads to the formation of the membrane attack complex, C5b through to C9, which causes intravascular hemolysis in the disease and its consequences. By blocking C5 from forming C5a and C5b, terminal complement inhibitors stop the symptoms that we see of the disease due to intravascular hemolysis. The first anti-complement therapy that was approved for treatment of patients with PNH was eculizumab, and this approval was back in 2007. Eculizumab is an intravenous treatment that is given as a 2-weekly infusion, and you can see from the graph of LDH, LDH levels are a very sensitive marker of intravascular hemolysis and typically very high in patients with PNH. When treated with eculizumab, those LDH levels come down very quickly to either normal or the top end of normal and remain at that level for the duration of treatment with eculizumab. The very first study was a pilot study of 11 patients treated with eculizumab in the United Kingdom, and this led to the pivotal phase 3 double-blind placebo-controlled trial, the TRIUMPH study, in patients with PNH. This study showed that more than half the patients treated with eculizumab during the 26-week period remained transfusion independent, whereas the patients on placebo were all transfused by week 14. The second phase 3 study, the SHEPHERD study, was then undertaken, and this looked at patients with PNH who required less transfusions and also allowed patients who had lower platelet counts, down to 30 times 10 to the 9 per litre, to be included. The patient-reported outcomes in the eculizumab clinical studies were that of the aortic QLQ30 score and the facet fatigue score. So the aortic QLQ30 score was devised for patients with cancer. PNH is not a cancer, but an improvement in any of the scores of 5 to 10 is a clinically meaningful improvement in quality of life. And you can see from the outcomes from the SHEPHERD from baseline out to 52 weeks for the duration of the study, there are marked improvements in the quality of life across many different parameters in patients treated with eculizumab. The facet fatigue score, a 3-point change, a 3-point improvement in facet fatigue score, is a clinically meaningful difference in fatigue in patients, and you can see there's a much greater than a 3-point improvement in patients treated with eculizumab in the SHEPHERD study, and this is maintained for the 52 weeks of the study. Ravulizumab was bioengineered from eculizumab. It is much easier for patients to have ravulizumab because the maintenance treatment is given every 8 weeks as an intravenous infusion rather than every 2 weeks. And you can see this within the first of the phase 3 clinical studies I'll talk about on ravulizumab, the 301 study. This is looking at patients who were naive to anti-complement therapy, and they were randomized between receiving eculizumab, the blue dots are when they received eculizumab, and ravulizumab, the red dots. And you can see the frequency of administration is much less burdensome for patients with ravulizumab. The patients were evaluated again for the aortic QLQ30, and this showed a maintenance of good scores, so a good quality of life in patients both on ravulizumab and on eculizumab. And when we look at these the global health status values, there were similar improvements seen in both eculizumab and ravulizumab. However, there is a higher percentage of patients in the ravulizumab group who had a greater than 10-point improvement in their global health status quality of life scores. And also, there was a higher percentage of patients in the ravulizumab group who had a greater than 3-point improvement in facet fatigue scores than in the eculizumab group. So a clinically meaningful improvement in fatigue. In the 302 study, this looked at patients who were on a stable dose of eculizumab who either remained on eculizumab or switched over to ravulizumab. There was a 26-week treatment period followed by a 2-year extension period, and patients who completed the 26 weeks on eculizumab were then able to switch over to ravulizumab for the extension period. The facet fatigue scores and the aortic QLQ were again evaluated in the 302 study. The aortic QLQ30 showed ongoing improvement and similar improvements in scores for both patients treated with eculizumab and ravulizumab. The FACIT-Fatigue score in patients treated with ravulizumab was slightly better than that of eculizumab, and the proportion of patients with a greater than 3-point improvement in their FACIT-Fatigue scores was also similar between the two groups. So again, showing a clinically meaningful benefit to patients in terms of the fatigue that they suffer because of the disease. When you look at both studies for both these outcomes, the FACIT-Fatigue scores or the aortic QLQ30, the benefits to patients has been proven over a longer period of time rather than just the time of the clinical trials. So a 2-year follow-up in both of these studies shows that ongoing improvement and maintained benefit in both quality of life and fatigue. So the third therapy to talk about is crovalimab. So crovalimab is administered based on weight. So there is an initial intravenous dose on day 1, and then weekly dosing subcutaneously from day 2 for the first month, and then monthly dosing as a maintenance treatment. The Commodore 2 study evaluated crovalimab compared with eculizumab in adult patients who were naive to anti-complement therapy. There was a 2-to-1 randomization to crovalimab over eculizumab. The patients were evaluated for a 24-week period, and then patients who were on eculizumab were allowed to switch over to crovalimab. You can see, similar to what I showed you with eculizumab, a very quick improvement in LDH levels consistent with control of intravascular hemolysis with crovalimab, and this is maintained for the duration of the study. The study looked at FACIT-Fatigue scores in both the patients on the crovalimab arm and the eculizumab arm, and you can see again a 3-point improvement in FACIT-Fatigue score is a clinically meaningful improvement in fatigue, and both of these therapies show clinically meaningful improvements. The Commodore 1 study evaluated crovalimab in comparison with eculizumab in adult patients who were on a stable dose of eculizumab. Patients were randomized between crovalimab or remaining on eculizumab in a 1-to-1 ratio for a 24-week treatment period. Patients who were on eculizumab were then able to switch over to crovalimab therapy. The changes in FACIT-Fatigue score showed an improvement in crovalimab over eculizumab, and with the mean difference between the arms being a 3.7. The FACIT-Fatigue scores in patients treated with crovalimab remained stable, and this was presented at the American Society of Hematology last year. There was also a cohort of patients who switched from ravulizumab to crovalimab. In this cohort of patients, there was an improvement in FACIT-Fatigue scores, which was again maintained, as you can see from this graph. So to conclude, the clinical trials of terminal complement inhibitors eculizumab, ravulizumab, and crovalimab all show significant improvements in their FACIT-Fatigue scores from baseline. The aortic QLQ30 scores show improvements in quality of life in patients treated with eculizumab and ravulizumab. However, there is a need for a PNH-specific reported outcome tool, as the QLQ30 was devised for patients with cancer, and this is ongoing at the moment. Thank you for your attention. Please continue to listen on to the next chapter, which is titled, What Do We Know About Patient Preferences?
Hello, my name is Dr. Austin Kulasekaraj. I'm a consultant hematologist based at King's College Hospital in London in the United Kingdom. In this chapter, I'm going to talk to you about what we know about patient experiences and preferences when it comes to receiving treatment for PNH. We all know anti-complement therapy initially started back in 2002 when patients had to have every 2-weekly intravenous treatments. And treatment for PNH is usually lifetime or long term. And patients usually present in the ages of 30 to 40. So this is going to be a long duration of treatment for these patients, and every effort should be made to reduce the burden for the treatment. We know that improvement to every 8 weekly treatment with intravenous C5 inhibitors have definitely reduced the burden. But notwithstanding that, patients still need to travel to hospital or healthcare setting, which can be time consuming, and it might totally disrupt their daily life. And patients need to be there for at least the period of half a day or full day. And this also leads to financial implications, not only for the patients, but also for their carers, and also the implication from their job perspective as well. Additionally, patients who require IV treatments are quite dependent on the hospital care setting. And it's also a constant reminder that they do have a medical illness or a medical condition which needs to be managed. And this is a qualitative analysis on a interview based technique to look to see what were the frequently reported PNH treatment burdens. And one of the top hits was financial concerns about the treatment, because PNH treatment does come with a cost, and interestingly, waiting time at the hospital, and so forth, as illustrated in this presentation, including time spent, burden of hospital visits, and restriction of travel, and also pain and discomfort caused by the infusion and injection. We all know that a number of the clinical trials have looked at patient preference in the context of different anti-complement therapy. And here we are looking at a patient preference study in this PNH 302 study, which was a sub-study looking at 11-item PNH patient questionnaire. And this was to see whether patients had preference to eculizumab, which is given every 2 weekly, versus ravulizumab, which is given every 8 weekly. And not surprisingly, overwhelmingly, patients did prefer ravulizumab. And one of the critical reasons for that is the frequency of infusions. And not only that, but the ability for patients to plan their activities and lifestyles, and also the overall impact on their quality of life, and also convenience, and also ability to control fatigue, which is another thing which we will talk about, because these patients, despite being controlled with adequate anti-complement therapy, do have the fatigue. One of the underreported issues related to IV or infusions, depending upon healthcare setting, is the anxiety, whether these patients will be able to get a cannula, they will get it on time, whether they will have the nurse come with the infusion, or in the hospital, whether the drug will be available as well. What about crovalimab, which, as you know, as a maintenance phase is given every 4 weekly as a subcutaneous, either healthcare professional administered or patient self-administered. And comparing it to eculizumab in the Commodore 2 trial, these were patients who were already established on eculizumab for a long period of time. And 84% of patients preferred the self-administered subcutaneous every 4 weekly options. And the top 3 reasons are indicated there, i.e., the way treatment was given was easier, fewer hospital visits, and time to administer this treatment was extremely short. What about patients who never had any previous anti-complement therapy? And here, patients preferred again crovalimab over eculizumab in both the arms when they were randomized. And similar to the previous study here, the top reasons indicated were fewer hospital visits, time to administer the treatment was shorter, and interestingly, the way treatment was given was easier, which is understandable because it's given subcutaneously, and also a better quality of life. In the small sub-study where crovalimab was compared to ravulizumab, which the latter is given every 8 weekly, again here patients did prefer the subcutaneous self-administered option in 2/3 of this group in comparison to 8 weekly IV infusions. And the reasons indicated were less time to administer, treatment was easy, And they were less worried about the venous access, which is something which is an important point to note as well. And patients were able to have the treatment at home at their own time and at their own leisure as well. But importantly, despite better modalities and other ability to give treatments, in the context of C5 inhibitors, especially here in eculizumab and ravulizumab, patients do continue to have fatigue, and this is reported despite not a significant difference in the hemoglobin levels as well, that these patients do continue to have fatigue. And looking at another study looking at fatigue and also global health status and physical functioning, you look at these patients who are adequately controlled on anticomplement therapy, and despite that, across US and Europe, these patients continue to experience some of the symptoms, i.e., fatigue, which has had a negative impact on the quality of life. So, though the burden of treatment is reduced, current treatments are not sufficient to completely remove the disease burden, mainly in relation to ongoing fatigue. And patients did prefer convenience and easier modality of administration, which had an impact on their quality of life. So, overall, hopefully, I've been able to take you through some of the issues related to PNH treatment. It's fantastic that there has been significant improvements in the treatment, but modality, frequency, burden, logistics of understanding to get the drug, and if there are oral treatments which are now available, patients need to look to see whether they did remember to take these treatments as well. Thank you so much for all your attention. Please do look at the patient handout and continue to answer the questions that follow to complete your evaluation. Thank you once again.
This program was presented by Medscape Education Global.